topic, bacterial endocarditis. I'm Dr. Mashood. I'm an interventional cardiologist at Morris Hospital. So what is the definition of bacterial endocarditis? It is defined as the infection of the endocardial surface of the heart. It usually involves the valves, but it can also involve the endocardium. It can also involve any septal defect. It can also involve the subvalvular apparatus of the valves. I do not find the total incidence of infective endocarditis in Pakistan. This is the only article which I find. It shows that there's a significant difference in the incidence of infective endocarditis in Pakistan as compared to the Western countries. We think it's mostly happening in younger population at presentation as compared to in Western countries, and there's an older population. So the classification of endocarditis, usually we classify as acute, subacute, but in general practical purposes, it usually classifies as native valve endocarditis versus prosthetic valve endocarditis. And sometimes based upon patients' prior history of intravenous drug abuse or their immune status, we can also classify them as nosocomial infective endocarditis versus normal person's infective endocarditis. But in most of the time, when we see the patient in the hospital, we usually categorize them as native valve endocarditis and prosthetic valve endocarditis. And the reason is the overall prognosis and the treatment strategy is different between two types of infective endocarditis involving native valve and prosthetic valve. Sometimes when the patient comes with acute presentation and they start to get very sick in the early part of the disease, then we think it's most likely acute infective endocarditis due to very virulent type of bacteria such as Staphylococcus aureus, Enterococcus, Pneumococcus. If they have a slow insidious onset of infective endocarditis, usually it involves rare organisms such as viridin, streptococcus, and sometimes enterococcus, but usually streptococcus viridins, which happen when people have some dental workup done. So what are the main predisposing factors which can cause bacterial endocarditis? Usually anything which involves manipulation of mucosa increase risk of infective endocarditis, such as any procedure involved with dental manipulation and dental disease, or any procedure involved a urinary tract such as cystoscopy or prostate biopsy. GI tract is rare, but if you're doing colonoscopy with polypectomy, then it increases the risk of endocarditis. But the most common cause is intravenous infusion. If you put a central line such as PICC line, which is a central venous line, or we use a IJ for administration of chemotherapy or antibiotics or some other chronic medicine, or people who have a dialysis catheter in the jugular vein or subclavian vein or femoral vein, those patients are directly exposed to bacteria and increase the risk of infective endocarditis. Patients who use intravenous recreational drugs, IV drug abusers, they also have increased risk of endocarditis. And usually within a few days after cardiac surgery, if the sterile technique is not used, it can also increase the risk of infective endocarditis. So what are the signs and symptoms of infective endocarditis? Prolonged fever, or what we call fever of unknown origin, generalized malaise, dyspepsia, not feeling well and feeling weak, arthralgia, nausea and vomiting are some of the non-specific signs of infective endocarditis. If the patient has a new onset of murmur or increase in the intensity of previously existing murmur increase the risk of endocarditis. In the late cases, patients have splenomegaly and they develop immunologic phenomena, what we call the glomerulonephritis. They can also develop vasculitis, which can be presented as hemorrhages on the nail beds, on the eyes, what we call Jinnah lesion and rod spots. If the patient have a very acute presentation and caused by very virulent organisms such as Staphylococcus aureus, it increases the risk of vegetation, which increases size rapidly and can shower into the brain or in the lungs. It's called infective embolus or emboli. Those patients have a rapid and poor prognosis. So the most common symptom of endocarditis is fever, chills, murmur is present in a lot of patients. In a generalized malaise, rapid weight loss, dyspepsia, and then we have some peripheral presentation which include splinter hemorrhages, Janeway lesion, rod spots. So the Osler nodes are subcutaneous nodules we see in the palms of finger and toes, and I'll show you the slide about them. It usually happened due to immunologic phenomena. These immune complex, which the antibodies which develop against the antigens of bacteria, and this immune complex then deposited in the palms of fingers and toes, what we call Osler nodes. They are painful. The Janeway lesions are the vasculitis, resulting in hemorrhages on the palms and soles, and the same process happened in the nail beds, what we call splinter hemorrhages. And the presentation of immune complex deposition is glomerulonephritis. So this is one of the examples of Janeway lesions. These are erythematous papules, you can see, or macules, seen in the palms of hands or palmar surface of the soles. And these are painless, and this usually happens due to underlying vasculitis due to infective endocarditis. Splinter hemorrhages, again, is a type of vascular phenomena due to vasculitis induced by infective endocarditis, usually seen on the nail beds. And then we have vasculitis causing hemorrhages in the retina, what we call rod spots. So these two slides represent rod spots. As I mentioned, that Osler nodes are subcutaneous nodules seen on the palms of hands, can be seen on the soles. These are painful, and these are due to deposition of immune complex in this area. So one of the diagnostic tests we do is blood cultures, and there are different ways to do the blood cultures. Should be done in 2 different sites and done 2 different times, and you should do aerobic and aerobic bottles. It helps for multiple things. It can help us diagnosing the endocarditis. It can tell us what antibiotics the bacteria is sensitive to. It can also tell us what antibiotic would be most effective. Okay. It also tells us the response to the antibiotics. If the initial blood culture were positive, and then after the use of antibiotic they become negative, that means they are responding to the antibiotic. So the most common cause of infective endocarditis is Staphylococcus aureus, and Staphylococcus epidermis is because of use of indwelling catheters or surgical wounds, and those patients develop this kind of endocarditis. It can also be on the right side of the heart in people who have IV drug abuse, but mostly it happens on the left side of the heart. So-called negative circulatory is mostly seen in prostatic valve endocarditis, sometimes also seen in native valve endocarditis. So the HASI group is also a typical organism which can cause infective endocarditis, and there are some types of organisms which are involved in HASI group: Haemophilus influenzae, Haemophilus influenzae, Actinobacillus, Cardiobacterium, Eikenella, and Klebsiella. And there are specific antibiotic designed for fight against these bacteria. Gram-negative is usually happen in people who have either colon cancer or who have urinary tract infection. There's specific organism which can, like Streptococcus bovis, which this is will be a board question that patient have Streptococcus bovis and infective endocarditis. And what kind of disease patient is suffering from, and the answer is colon cancer. Salmonella is also one of the common causes, but usually E. coli due to UTI or Streptococcus bovis due to colon cancer can cause gram-negative infective endocarditis. Pulmonary endocarditis has happened in immunocompromised people. Candida aspergillus are the common causes. It usually happens in people who have underlying immunocompromised conditions such as malignancy or who have advanced stage of hepatitis B or HIV. So besides the blood culture, what other tests we can do to diagnose the patient with endocarditis? We can do a CBC if the patient has a little blood count, or ESR that increases risk of infection, complement levels, rheumatoid factors, as well as ESR. They all the signs of inflammation. So if they're elevated, it means patient having possible infection inside. Urine analysis is to diagnose a patient the source of infective endocarditis. If patient has E. coli in the urine, more than 100,000 colonies, same time they have positive blood cultures, endocarditis is most likely E. coli endocarditis. And we do the chemistries, and the purpose of chemistry is to check patients' underlying kidney functions and renal function to see what kind of antibiotic will be safe to give in these kind of patients. Then we do the chest x-rays, and chest x-ray, the purpose is to see the patients have infective emboli in the lungs. If they are, then most likely they are suffering from the right-sided infective endocarditis. And mostly it's happening in people who are intravenous drug abusers. The purpose of ECG is to rule out the complication related to infective endocarditis, because if the people have a first degree AV block or intermittent conduction delay, but most importantly, they have first degree, this will be a board question. Patients come with suspicions of infective endocarditis and they have a first degree AV block. It's most likely they're developing abscess in the cardiac fibrosa, and it requires immediate antibiotic therapy and most likely surgery. So this is one of the examples of vegetation and abscess. If you can see around 3 o'clock, there is a vegetation. And if you can see there's a space in the cardiac fibrosa, then it is representing an abscess just above the aortic valve. And those patients are candidate for early antibiotic therapy, and they're responding, then surgery is the best option. Now, if you see the diagram, the picture on the left side, the top is the left atrium. On your left side, extreme left side is the right atrium, and between is the aortic valve. And if you can see, it has the acidic sign showing that it looks like there's abscess developing in this area, and there's a communication between the aortic valve and abscess. So this patient most likely have aortic valve endocarditis, and he's developing a fistula in that area. And if you can see, there's a color jet going from the aortic valve in the right atrium. So he's developing a fistula or could be developing sinus or valsalva aneurysm. So this is the complication of infective endocarditis, and those patients require urgent surgery. One more echocardiogram. On your top left side, on the arrow sign, you can see there's a thickening, significant thickening of the non-coronary cusp of the aortic valve. So this most likely vegetation. And if you have a actual video, you can see that this vegetation have a free movement on both sides of the chamber in the alveolar flow tract and the aortic root. So this most likely represent infective endocarditis. On the top right, you can see by yellow arrow sign, you can see there's a mass in the aortic valve, which represent vegetation. And the bottom blue sign in the same picture, you're seeing an echo space, a dark space, and that's most likely represent an abscess. On the bottom right picture, you can see the yellow sign showing vegetation, and the bottom blue arrow is showing an echo space, a dark space between the shining cardiac fibrosa. That dark space between the shining cardiac fibrosa is basically an abscess. And you can see on the bottom right picture that there's a significant amount of color jet going from that area. So this patient is developing abscess and most likely dehiscence of the valve. So this arrow is representing an abscess in the cardiac fibrosa just above the aortic root. This is the transesophageal echocardiogram. On the left side, there are multiple arrows showing multiple masses in the mitral valve. The top chamber is the left atrium, the bottom chamber is the left ventricle, and between the left atrium and left ventricle is the mitral valve, which has multiple masses. And these masses on the upstream of the valve, so they represent infective vegetation. If the masses on the downstream of the valve, which means they're on the left ventricle side of the mitral valve, then they most likely could be non-infective vegetation, such as happen in lupus, what we call embryonic endocarditis, or it can happen in the people who have papillary fibroblastoma. So if you see a mass in the mitral valve facing the left ventricle, those masses oftentimes due to non-infective vegetation or due to a tumor called papillary fibroblastoma. If you see a mass facing in the mitral valve facing the left atrium, this is most likely infective vegetation. Now the right side picture with the arrow, this represents endocarditis of the tricuspid valve, and it is near the mitral valve. Near the aortic valve. So the echo space suggests between aortic valve and tricuspid valve is an abscess, and those patients require antibiotic and most likely surgery. So how we diagnose the infective endocarditis? We do multiple testing, which include CBC, blood test, blood culture, CBC, ESR, and then we also do an echocardiogram if the patient have high suspicion of endocarditis. So the Duke University developed this criteria. There are two major criteria to diagnose infective endocarditis. One is a blood culture. So a patient has to have a blood culture in two separate bottles, at least 2 hours apart, or most 12 hours apart. And it has to be positive for typical organism, which can cause native or prosthetic valve endocarditis. After having positive blood culture, we do the echocardiogram, And it will be a transthoracic echocardiogram, or what we call surface echocardiogram. And still there is suspicion, or if the quality of surface echocardiogram is not good, then patient would require a transesophageal echocardiogram. And the purpose to identify a mass attached to the valve or the supporting structure, like a chordae tendineae, or a mass attached to the prosthesis deployed in the heart, or an indwelling catheter, which is inside the heart, or if you see a sign of damage to the valve, such as abscess, fistula, or dehiscence of the valve. So this is the definition of the echo involvement of the infective endocarditis, which means there's a free-floating mass or oscillating mass attached to the valve or supporting structure or any implanted device. And it's free-floating and usually on the atrial sides of the mitral and tricuspid valve, and should be the aortic sides of the aortic valve or pulmonic side of the pulmonic valve. And it usually associated with aortic, associated with the regurgitation, such as aortic regurgitation or mitral regurgitation. Or if you don't see a mass, if you see signs of valve damage, such as patient have abscess, or patient had dehiscence of prosthetic valve, or patient develop significant valvular regurgitation, it has to be new. It cannot be a worsening of previously existing regurgitation. So what are the minor criteria? Minor criteria means a patient have pre-existing condition which can increase the risk of infective endocarditis, such as history of infective endocarditis, or history of intravenous drug use, or a patient has history of cyanotic heart disease which were not repaired or partially repaired or repaired with some residue, or it involved using the prosthetic material, or the patient has history of prosthetic valve replacement, or patient have history of atrial septal defect which was repaired with the prosthetic material. If the patient also have fever above 38, it's considered one minor criteria. Then we have vascular and immunologic phenomena. The vascular phenomena means the patient develop Osler nodes, Roth spots, Janeway lesions, pulmonary emboli in the lungs, or conjunctival hemorrhages. The immunologic phenomena include glomerulonephritis, positive rheumatic fever antigen, or patient have positive blood culture or just the one positive blood culture, or the positive blood culture not specific which cause endocarditis. That's considered minor criteria. So the patient should have two major criteria or one major and three minor in order to have a certainty that they have an infective endocarditis. So the certain criteria to diagnose infective endocarditis means by Duke criteria of two major and one major and three minor. What are the complications of infective endocarditis? As I mentioned, patient can develop abscesses, they can develop valve dehiscence, they can develop severe regurgitation. If they have abscesses, they can also develop heart block. They can also develop significant myocarditis, which means inflammation of the entire myocardium, which can result in life-threatening arrhythmias. They can also develop stroke or ischemic limb due to shower of emboli in those areas. If the emboli goes to the brain, they can cause meningitis. And the antibodies develop against the antigens of bacteria, which can result in immunologic complexes such as glomerulonephritis or arthritis. So if the patient develops significant valve damage resulting in valvular regurgitation, those patients develop heart failure. And the treatment is antibiotic as well as diuretics. And then you have to closely follow those patients. If they are refractory to medical therapy, then they require surgery. So what are the antibiotics we give for patients who have infective endocarditis? If they have streptococcal or enterococcus infection, 4 weeks of intravenous penicillin with 2 weeks of aminoglycoside, or they will need 4 weeks of ceftriaxone. If they can also may need vancomycin 4 weeks with 2 weeks of aminoglycoside. If they are involved with HASAC group, and then ceftriaxone for 4 to 6 weeks. If they have staphylococcus aureus infection, if they are methylene sensitive, then they will require oxacillin along with the 2 weeks of aminoglycoside. If they have MRSA, which means methylene resistant staphylococcus aureus infection, they will require 4 weeks of vancomycin, 2 weeks of aminoglycoside. Sometimes we also give them rifampin. We also start giving them linezolid if they're not able to tolerate vancomycin, or if they develop a C. difficile with vancomycin. But it reserved only if patients cannot tolerate vancomycin. It's called linezolid, a new antibiotic. Prosthetic valve endocarditis. So the first year, and some books say it's first 2 months after the deployment of prosthetic valve, the endocarditis develop has a different organism, and after 1 year they have a same organism which causes native endocarditis. Oftentimes the prosthetic valve endocarditis in the first year they are slightly immunocompromised, so they can develop infection due to indwelling catheters, and most of the time they are infected by Staphylococcus epidermis. And the treatment is 6 weeks of vanco or of fluocloxacin plus 4 weeks of aminoglycoside and 2 weeks of rifampicin. Now, what are the patients, or who are the patients who require surgical intervention? So there are different criteria that American College of Cardiology recommended that if the patient has unchanged size of vegetation despite prolonged antibiotic therapy and have a signs of systemic embolization, then they are candidate for surgery. Or if the patient has vegetation above 15 millimeter, they have a high risk of developing embolic stroke, or it can also cause it can throw the embolize into the lungs also if they have a right-sided endocarditis. So those patients will require surgery. Or if the patient develops severe mitral aortic regurgitation resulting in signs of heart failure, then those patients will require surgical replacement of the valve. If the patient develops complication to the valve, such as valve perforation rupture, in case of a prosthetic valve, they develop a severe perivalvular leak, or to develop valvular dehiscence or fistula, or they develop significant abscess causing new heart block, those patients require a valve replacement, and this requires surgery. Now, we always get calls about patients from the dentist, that patient going for dental procedure, and do they need their antibiotic prophylaxis. So any dental procedure which cause gingival or mucosal manipulation, even clean the teeth or implant of the teeth, which can cause manipulation in the mucosa of the mouth, they will require antibiotic prophylaxis if they have following conditions. If they have a history of valve replacement, or they have some kind of procedure in the heart which require use of prosthetic material. If the prosthetic material was used in the last 6 months, so if they have a prosthetic valve, or in the last 6 months they have a surgery which have required use of prosthetic material in the heart, or if they had previous history of infective endocarditis, then they will require antibiotic prophylaxis. And there's a whole gamut about patients who have congenital heart disease. So if they have cyanotic heart disease unrepaired or repaired with residual defect, or if it involves using prosthetic material, then they will need antibiotic prophylaxis. If they have a cardiac transplant and they develop valvular abnormalities after cardiac transplant, they also require antibiotic prophylaxis. So what are the antibiotics we can use? It's very simple. I always call them and tell them the patient will need 2 grams of amoxicillin IV or PO. IV can be taken an hour before. PO can be taken up to 2 to 4 hours before the procedure. If they're allergic to penicillin, then 600 milligram of clindamycin, or we can use Zithromax or erythromycin 500 milligrams. Now, what are the new perspectives about infective endocarditis? We're trying to come up with a vaccine which can be given to people who are prone to have infective endocarditis. And as I said, those patients, immunocompromised patients, or who has previous endocarditis or intermediate drug use, or people who have prosthetic valves, especially prosthetic mitral or aortic valve, or people who have history of cyanotic heart disease, unrepaired or repaired with residual defects. So in those kind of patients will be benefited from Staphylococcus aureus vaccination. So some of the new antibiotics, as I mentioned, that linezolid is a new antibiotic and is being used in pupils who cannot tolerate vancomycin. Like you started the vancomycin and they develop C. difficile infection, or the patient not responding to vancomycin. So then those patients can receive linezolid. Daptomycin is a new antibiotic. It is rarely used, and when you talk to infectious disease doctor, they're trying to reserve these antibiotics in a very special case and try not to use in every single case. Otherwise, patient will develop resistance to these antibiotics. If you have any question, please email me. Thank you very much and good luck.